I think we'll get started. This session is supported by an educational grant by Mallinckrodt. So my name is Kevin Regner. I'm a nephrologist from the Division of Nephrology at the Medical College of Wisconsin in Milwaukee. I'm joined by Dr. Mitra Nadim and Dr. Hugo Vargas. Dr. Nadim is a professor of clinical medicine at the Keck School of Medicine at the University of Southern California. She is nationally and internationally known as a nephrologist with expertise in the area of AKI in critically ill patients in the ICU, especially those with cirrhosis. And she has co-organized and participated in several international consensus meetings that have resulted in significant contributions to the field of AKI, including what she's going to talk about today, the updated AKI guidelines. Dr. Vargas is a professor in the Division of Gastroenterology and Hepatology at the Mayo Clinic Transplant Center in Phoenix. He has an active interest in portal hypertension and acute on chronic liver failure, and has participated in randomized clinical trials that have led to terlipressin being approved in the United States. So please let me welcome Dr. Nadim for the first presentation.
Good morning, everyone. Thank you for waking up this early, especially the West Coast people like me, where it's 3:30 in the morning for us. So over the next 20 minutes, I'm going to highlight some of a recent, well, it's not recent, it was published last year, but a consensus meeting between they're not really societies, but the AKI and the International Club of Ascites regarding some new recommendations about workup, definition, and management of patients with HRS-AKI. These are my disclosures. As I mentioned, what I'm going to be talking about is the result of a consensus meeting. It was international, multidisciplinary. You can see nephrologists, hepatologists, critical care. Folks were all involved, including some of the pediatrics, and we had a pharmacist also involved. So I'm going to start with this is a case. It's a typical, patients that we see, 65-year-old with MASLD, which is the new terminology for NASH cirrhosis, admitted encephalopathy for expedited liver transplant evaluation. And the complications, they had liver complications of ascites, the typical lower extremity swelling, encephalopathy, varices, has underlying type 2 diabetes, baseline creatinine of 1.3, and the home medications were on diuretics and some propranolol, insulin. And recently, the diuretic dose had been increased due to worsening edema. On physical exam, the blood pressure was low, oxygen saturation 96%. There was evidence of anasarca, ascites. And again, this is typical patients that we see transferred to our institution, lethargic, but was still arousable. On laboratory studies, the sodium was 128, potassium was elevated, BU and creatinine the creatinine had increased from baseline 1.3 now to 2. INR elevated and bilirubin ultrasound, really nothing remarkable other than cirrhosis, and a para was done, which was negative for SBP. So what's the next clinical decision? Would you give albumin for 48 hours in the setting of the AKI, octreotide midodrine, terlipressin albumin, insert an HG catheter, or none of the above? And I think you just scan this and put your answers in. That's good. Okay. So the majority was the IV albumin, which hopefully I can change your minds by the end of the talk. Which of the following would help you refine the cause of AKI? Discontinuation of the diuretics and giving albumin would help you decide what the cause is. A FeNA, urinary NGAL level, or none of the above, or all of the above. Okay. For the sake of time, we will go on. So just some historical background, because it shows kind of how we evolved into these new guidelines. So if you go back, this is close to now 45 years. The first definitions there was no definition for AKI really until 2012. And prior to that, it was just HRS, the first one coming out in 1979. And you can see it took 25 years for the AKI group to come up with the International Club of Societies definitions for AKI. And this was then kind of adjusted a bit in 2015, and then again recently a publication with the consensus meeting of, again, revising these definitions, both of AKI and HRS. So what was proposed back in 2012? Again, as I mentioned, the only definition that existed was for HRS. And what we basically proposed, and this was, again, a multidisciplinary international consensus meeting, we just recommended the AKI criteria. The KDIGO wasn't existing then, and we basically suggested that patients with cirrhosis shouldn't be any different from the general population of AKI. And so they should follow the same definition with a serum creatinine greater than 50% or a 0.3 milligram increase in 48 hours. And the other thing we also suggested, which again, for right now, it may seem that this is obvious to the nephrologist, but for the hepatologist, this was something very important to understand, that you can have underlying kidney disease and on top of that develop AKI for various reasons, even HRS AKI. And especially with this era of increase in MASL, so you have more metabolic syndrome, diabetes, there's going to be a lot of patients with underlying diabetic kidney disease, but on top of that, they can develop HRS. And we suggested that, the type 1 that used to, type 1 and type 2, that type 1 would be defined really like considered as an AKI because it was very quick, versus the HRS2, which was the refractory patients, that they would be considered as CKD. In 2015, the Hepatology Society, the International Club of Ascites, adopted that definition. Again, it was the same. Now KDIGO was out, which for those of you is very similar to the AKI criteria, but they only considered the serum creatinine criteria, no urine output criteria. And they felt that the urine output, the reason they didn't want it included is that they felt the patients are often oliguric. So the urine output criteria for KDIGO, may not be accurate. These patients usually have urine outputs that may be increased from diuretics, and they felt that on a regular ward, urine collection is often inaccurate. So they just felt that they don't want to include it. Well, this triggered Dr. Kellum in Pittsburgh to actually analyze their own data. This is on over 3,000 patients. Okay, this is really loud back there. Over 3,000 patients with liver disease. And what they found, again, I don't know if those of you who were in the AKI session yesterday, this data was shown in all ICUs, and he took those cohort of 3,000 patients. And what you can see here on the top row, patients who don't meet AKI criteria based on serum creatinine, but they met the criteria based on KDIGO's urine output criteria, their mortality was 22%. And that's actually even higher than if they met serum creatinine criteria, so they tripled their creatinine, but their urine output did not meet criteria, the mortality was 13%. And like all patients in ICUs that have been studied over the past 20 years, if you have both urine output criteria and serum creatinine criteria for AKI, your mortality is quite high at 50%. So this was the first to show that, urine output is important. Despite this study of 3,000 patients, the Hepatology Society guideline still, did not want to put it in their guidelines, but there was some highlights in the text if you read it. The EASL, which is the European guidelines, suggested that there is a urine output criteria for KDIGO, and you can apply it if they have a Foley catheter. The U.S. guidelines, which I was involved in, also, unfortunately, it was just me, single nephrologist, in the months of all the hepatologists. I couldn't get it in, except for a statement saying that, a measurement of the urine volume is important because oliguria is associated with poor prognosis. Well, the AKI and ICA consensus meeting, as I mentioned, we recommended that the AKI definition, acute kidney disease, CKD, in patients with cirrhosis should be defined using the KDIGO criteria, both serum creatinine, urine output, whatever criteria is used by KDIGO, these patient populations should not be any different. And here you can see that these patients have had underlying AKD, CKD, or no kidney disease, they have some kind of exposure, whether it's sepsis, whether it is large volume para, and they develop AKI, and they can either recover, but again, they can progress to AKD, which is associated with a higher risk of dialysis and mortality, and they can progress also then to CKD or ESRD. So going back to the HRS criteria again, to understand how we came up with the new guidelines, I think we have to go back in history to say, where did it start from? Again, this was 1979, the first criteria, and it was in a book. It was published in a book. But I highlighted, which is very interesting, because it seems like at that time they got it correctly, and then somehow over time things change. But they said, no improvement in volume expansion, but they put a CVP of 10, suggesting they put a cap on how much fluid you give. In other words, if the patient's volume overloaded, I guess they were measuring CVPs then, don't give fluid. So this was just give it up to 10. They suggested that, the urine may have granular casts, suggesting that it may not be this pure, clean urine that we always have associated with HRS with. And they said that, the initial characteristics of the renal failure may be followed later with tubular dysfunction, suggesting that you can go from one form of AKI in this patient population to ATN and still qualify as being HRS-AKI. Then there was a 1994 update, and then again updated in 2007, which was very similar. But you can see here, all of a sudden, again, the serum creatinine of 1.5, but this cap of fluid just kind of got uncapped with 2 days of volume expansion, regardless of what your volume status was. And then there was this issue of, you have to have no evidence of any kind of structural kidney disease, which was defined by proteinuria of more than 500 or microhematuria. And again, as nephrologists, for us, this is a problem because, again, there's a lot of diabetics. There's a lot of patients with alcoholic underlying IgA nephropathy. It doesn't mean that they have acute GN, but they may have hematuria that is more than 50 RBCs. But these patients were excluded from any kind of trials or treatment during this whole era. Once the, definition for HRS-AKI, got revised by the AKI group, the International Club of Ascites in 2015, here you can see they removed the serum creatinine criteria, and they said the KDIGO serum creatinine criteria only, no urine output, but they kept everything else still there, the 2 days of remove diuretics, give 2 days of volume, and this perfect kidney with no proteinuria. The EASL guideline I have under there also further decided to subdivide the type 1, the AKI stage 1. And again, they threw in that serum creatinine of 1.5, saying, if for the staging of AKI, where we have stage 1, 2, 3 by KDIGO, they said, well, there should be a stage 1A and 1B. And that 1B cutoff of creatinine of 1.5 is where EASL is suggesting you start terlipressin, which again, in my opinion, is wrong in patients who are very sarcopenic, whose baseline creatinine may be 0.4. If they go to 1.2, they've already tripled their creatinine, they've dropped their GFR by 75%, yet if it doesn't meet the 1.5 based on EASL, the recommendations is different. But they did say that these patients, they understand that even though they say no macroscopic sign of kidney injury, that they can still have some structural damage, again, throwing in this idea of maybe biomarkers and that the urine may not be as, the UA that we usually think is perfect may not be completely normal in these patients. So this now has brought us to the last recommendation or guidelines that we proposed. You have the cirrhosis. The AKI defined by KDIGO, not only serum creatinine, but also urine output, if you can measure the urine output. So it doesn't mean you go and put a Foley, and we tried to explain this, is not to go and put a Foley in a patient just to measure it. But if you can measure the urine output, if you do have a Foley catheter for whatever reasons, pay attention to it. If the urine output, yes, they usually are low, but if it keeps dropping, that's a sign of AKI. Absence of improvement in serum creatinine and urine output within 24 hours following adequate volume resuscitation only when it's clinically indicated. If the patient does not need volume, you do not need to give volume back to these patients. Absence of a strong evidence for an alternative explanation as the primary cause of AKI. This is to suggest you can have two things happening at the same time. It's you know, the cardiologists have it right. The cardiorenal that they say, you know, you can have florid heart failure, and at the same time, someone gave vancomycin and the creatinine went up and the vanco levels high. You can have two things going on at the same time. You just have to see what is the driving force of causing the AKI. And the cardiologists still treat the heart failure, and they say, well, we gave contrast, we did vanco, we have that on the side, but we're still going to treat the, cardiorenal, the heart failure section. With patients with cirrhosis, somehow we have stopped saying, nope, you either have to have this or that, and not understanding that both can happen at the same time. So this statement is very interesting. We put the statement, we recommend against systemic administration of albumin for 48 hours as a requisite for the diagnosis. It was a strong recommendation, but you would think that we took the safety blanket away. It has created a lot of noise. If you look at the paper that was published, there's a lot of letters to the editors over the last 2 years that we have to respond to because they feel like this 48 hours needs to go back in there. But if you look at the data, again, one of the problems, and this is not that I have any experience with terlipressin because it's not at our institution, but my feeling is it is not so much the drug that is the problem, it is what we do before we give the drug, and the biggest problem was albumin. So if you look, these are the 3 North American studies that were on terlipressin. These were the randomized large trials. Prior to even starting giving them terlipressin, if you look at the maximum amount of the range of the maximum amount of albumin, it was 1,000 grams. That is 40 bottles of 25% albumin. This is a lot of, and this is just before they get randomized. Then, when you give terlipressin, then they're giving more albumin. The guidelines say, 20 to 40 grams per day with, terlipressin. The majority of the Europeans all give just 20 grams, which is a bottle, like a 100 cc bottle of 25%. But look at the dose. The maximum amount daily was 150. That is 6 bottles of 25% albumin. So of course, these patients, by the time they get to, any kind of treatment, it's going to tip them over into problems. So again, this albumin, despite all these guidelines, you can see how much people were giving. And so this has caused, again, you would say, well, how did these people get 1,000 grams or this much? Well, it's because everything has albumin attached to it. You get a patient with cirrhosis, their blood pressure drops, someone orders albumin. SBP, give albumin. AKI, give albumin. Urine sodium is less than 20, give albumin. Lactate goes up a little bit, give albumin. Paracentesis, give albumin. And we have forgotten, well, what is the data for all of this that even existed? And I'm not going to go through all the data, but the one I'm going to talk about really is this SBP because it's very common that we see it and we give it, but you have to go back. What does the data show? So this is the data that was that became the law of the land. It was in the New England Journal by Paraginis's group, 1999. So we are looking at 45 years ago. I mean, some of my fellows probably weren't even born then. And this study was a small study, 63 patients, unblinded, randomized controlled trial. And for those of you who wondered why it's day 1 and day 3 giving albumin, well, if you read the paper, it says that's when they were checking labs. So you have to wonder, why are we giving day 1 albumin and day 3? What happened to day 2? Why not day 2? And they defined renal failure as this BUN of more than 30, serum creatinine of 1.5. Already 40% of the patients already in this study had renal failure. We have used this albumin use as a prevention of AHRS. These patients already 40% going into this trial already had AKI. And you can see the albumin was low. For those of you who are in transplant centers, by the time patients get to us, we have albumins that are in the 6 range. They have gotten so much albumin in the outside hospital, and then they come to our institution, the resident just orders, albumin for HRS, to rule out HRS. And again, you can see here, yes, the study was a positive study. They found, less AKI. But if you look again at the table of the serum creatinine, look at the difference between those who got albumin or not. It was a difference between a creatinine of 1 plus or minus 0.1 and 1.3. It didn't even meet their own criteria of 1.5, which was defined as AKI. So they mainly went with the BUN part of it, which gave them some positivity. But they also indicated that the incidence of AKI in patients with less than T-billy less than 4, serum creatinine less than 1, BUN is really low. I think it was close to 0. They don't even recommend it. But I don't think anyone even read that part of it, and we still give it. Anyone who has SBP, regardless of what their billy is, we throw in a dose of albumin. And they themselves said, it's expensive in Spain, limited availability. Studies should be performed to determine whether treatment with lower dose of albumin with less expensive would have similar beneficial effects on renal function and survival. And you would think this would be a very simple study to do. This was 45 years ago. It has never been replicated. There's only one letter to the editor, which again, you can't really consider it saying that they showed that lower dose was helpful, but again, it was a letter to the editor. But for 45 years, this has become the law of the land of giving all this albumin day 1, day 3 for SBP based on this study. So what have we recommended in the in the AKI group, in the consensus? So, yes, you have this issue of you can do volume status, and everyone keeps saying, well, how do you assess volume status? Well, it is hard. But, there's a lot of tools available. The first tool is looking at the patients. People forget to look at the patient. If the patient is hypoxic, if the x-ray is wet, if they have anasarca, you do an echo, the RV systolic is high. These are all suggestive of, high volume overload. And these patients, don't stop the diuretics. You actually may need to give the diuretics. And even in Europe, the Europeans I've spoken to, they give some diuretics before they start the terlipressin, because they know if the patient becomes too volume overload and you give the terlipressin, which you're going to hear, you can get into trouble. So maybe make them a little bit drier and then start giving these medication. But if you have volume depletion, true volume depletion, then give colloids, crystalloids, LR, there's plasma light. There's no need, a lot of times we see the hepatologist give 25% albumin, 100 cc's. Well, if a patient's volume depleted, 100 cc's of volume is not going to do anything. So give them adequate volume. If it's equivocal, you can give albumin. We conceded on that, or I give just crystalloid. But after 24 hours, you should see if the creatinine's not getting better, then there's a problem. There doesn't need to wait for 48 hours. If it's getting worse, because volume should be improving if they have, volume depletion. Then there's this issue, is it HRS, AKI, ATN, or can you have kind of both of them together? And about removal of fluid, again, if the patient shows really significant evidence of volume overload, you got to restart the diuretics. You may need to consider renal replacement therapy. You have to individualize it for, it's different on each patient. But we had this many years ago, I think when I first started, this idea of, well, the hepatologist has to list the patient before we dialyze them. Well, that's the wrong mentality. You got to start preparing. If they're considering for eval, then if they need dialysis, then start it. Don't wait till they, are too sick even to handle that. Then you start de-escalating and peeling back on these patients if, for example, they're not a candidate. Just a few slides on biomarkers going to be discussed, because can that help with differential diagnosis? Just to show that FeNA, the AUC of FeNA is 0.5. That's a flip of a coin. So this FeNA that we used to hang our, hats on is no longer really, it's helpful if it's really high, but if it's less than 1, it's not helpful. NGAL now is FDA approved pediatric use, but once it's FDA approved, if you have access to it, something to consider. And this framework we put in our paper is, and you will see this image in a lot of AKI meetings because it was started by AKI 15 years ago, and for every disease, it's the same thing. You just put in different, diseases in there. But it basically is showing that patients can be in any of these boxes, and they can go from one to the other. You can have a patient who has normal serum creatinine or urine output, but has positive damage markers, has albuminuria, hematuria, urine NGAL is positive. They may have subclinical AKI, and you don't see the dysfunction until later on. Or you may have a serum creatinine that's positive, that's up, dysfunction is positive, but damage negative, so HRS, AKI, or AKI. But more importantly, you can have both of them. You can have damage marker that are positive and dysfunction. This can be either AKI from ATN, AIN, GN, or you can have HRS AKI, which is a coexisting damage. And again, we should be looking, and this will be discussed more detailed, the treatment, when we talk about these treatment, and this is why it's so important, we get so fixated, HRS, ATN. The Europeans, if they feel like it feels like HRS, they give terlipressin. In 3 days, they'll have an answer. If there's no improvement, they stop. Because if you go by just specific one biomarker or your own opinion, you can see or you can miss 30% of the patients who could have responded to this. And again, early treatment is the most important thing. That's why our guidelines have removed that 48 hours. This you can see here, the earlier you start, again, this will be discussed in the next talk, the earlier you start, the better your outcome is going to be in regards to medication. And the confirmed trial showed that only 30%, but you can see here, the average start of creatinine was 3.5 already in the US trial. So thank you very much. And this again was this was from the consensus meeting, and this is the group that was involved in that study, in that meeting. Thank you.
So as I said before, we'll hold questions till the end of the 3 talks. That was great. Thank you very much for that excellent summary of the updated AKI guidelines. And I'm going to build upon a lot of what Dr. Nadim discussed as I discuss a stepwise approach to the diagnosis and management of HRS-AKI. So as a disclosure, I've been on advisory boards for Mallinckrodt, the manufacturer of terlipressin in the US. So we'll talk about the range of etiologies of AKI in patients with cirrhosis. We'll talk about guideline recommendations for how we evaluate AKI in these patients. We'll discuss the 3 vasoconstrictor regimens that are used in the United States for treatment of HRS-AKI. And we'll talk about how we can appropriately select patients for vasoconstrictor therapy and how we can mitigate adverse effects. So when I think about the 4 steps that are necessary to go from identification of AKI to ultimately treating HRS-AKI with a vasoconstrictor therapy, these are the 4 that I came up with. And what I'm showing here is descriptions directly from the updated AKI guidelines about what they say about this approach. So the first step, as Dr. Nadim discussed, was to identify the presence of AKI using the KDIGO criteria. The second step is to perform a diagnostic evaluation to identify a specific cause of AKI, and we want to use tools similar to those used in patients without cirrhosis, including clinical history, exam, including volume status assessment, and identification of potential precipitants. Then we want to diagnose HRS-AKI using the updated ICA ADKI diagnostic criteria. And then we want to implement vasoconstrictor therapy with terlipressin as the first-line agent in combination with albumin immediately upon diagnosis of HRS-AKI. So thinking about the step 2, the differential diagnosis of AKI and making a specific diagnosis, of course, as Dr. Nadim pointed out, this can be somewhat challenging and there's overlap of many of the phenotypes. So patients with cirrhosis can have pre-renal AKI due to typical volume losses or due to volume losses that might be particular to cirrhosis, like lactulose use or GI bleeding or diuretics for ascites. They can have glomerulonephritis that's either associated with their liver disease or not. They can have interstitial nephritis, ATN from nephrotoxic or ischemic causes. They can have obstruction and any number of other causes of AKI. And of course, they can have HRS. And what's being pointed out on this slide is that there are overlaps in the phenotypes of AKI in these patients, and it's our job to differentiate them. So what are the three main causes of AKI in patients with cirrhosis in the United States? This is data from the HRS Harmony Research Consortium showing data from over 2,000 patients with AKI and cirrhosis at 15 medical centers in the US. And what we're showing here is that the most common cause of AKI in these patients is prerenal AKI at 44%, followed by ATN at 30%, and then HRS AKI at 12.1%. Importantly, HRS and ATN have comparably poor 90-day survivals in contrast to prerenal AKI. And so it's really our job to determine which of these three main causes is the cause of AKI in our patients. So what are some of the tools that we can use to differentiate these causes? So as was mentioned, we can use FeNA, we could use urinary sediment, and we can use biomarkers, and there's pros and cons to each. So for example, the FeNA less than 0.1%, not 1% that we might typically think of in the non-cirrhotic population, FeNA less than 0.1% may distinguish HRS from other causes of AKI. The challenge with that is that many clinical labs don't report urine sodiums to below 20, which makes it difficult to actually calculate a FeNA as low as 0.1%. We can use urine sediment analysis because muddy brown casts on microscopy do predict the presence of ATN on biopsy, but again, that may be beyond the expertise of the non-nephrologist. And of course, we can use biomarkers with urinary NGAL being the prominent one because this has been shown to differentiate ATN from other causes of AKI. But again, urinary NGAL is not widely available or approved for adults in the US. So as an example of how we might apply these tools, I'm showing data from the Yale group looking at their prospective study of urinary biomarkers for AKI and cirrhosis. On the left, we see, as I pointed out earlier, patients with HRS tended to have very low FeNA, around 0.1% or lower, whereas patients in the middle panel with ATN tended to have high urinary NGAL levels. When you look at the ROC curves, you see that the best performing biomarker was urinary NGAL at a cutoff in this study of over 365 nanograms per ml. So that was able to discriminate ATN from other causes of AKI. So what do the guidelines say about the use of urinary biomarkers? So I'm showing EASL, AASLD, and ADKI recommendations. So in 2018, EASL said that urinary NGAL can be used to distinguish between ATN and HRS, but they don't provide a cutoff. In 2021, AASLD stated that urinary NGAL was the most promising biomarker, and the best time to check this was at day 3, with a urinary NGAL cutoff of 220 micrograms per gram creatinine. And then in the ADKI guidelines, as Dr. Nadim just discussed, they suggest complementary use of functional and damage-related markers to aid in the detection of AKI, characterization of AKI phenotypes, and to guide treatment strategies. And they suggest a urinary NGAL cutoff of 220 to 250 micrograms per gram creatinine. So if we put it all together, this is kind of what we would want to see happen. We want to, step 1, identify the presence of AKI. We want to perform our comprehensive diagnostic evaluation to identify a specific cause. So for example, on the right, if we find hydronephrosis and we have obstruction, we're going to treat that appropriately. But most of what we're going to see is in the middle of this chart here, where we have maybe some muddy brown casts, maybe a low FeNA, maybe a clinical history and a physical exam that suggest the presence of HRS AKI, and we have to kind of make a decision about whether we're going to go ahead with vasoconstrictor therapy or not. And I think, as you heard in Dr. Nadim's talk, ADKI suggests that we probably be less conservative in being too strident with our definitions of HRS AKI, and we give patients a time-limited trial. So let's go back to the patient case. So the patient undergoes risk factor management with volume expansion with albumin. The serum creatinine rises from 1.3 to 2. Ultrasound was negative. UA showed no cells, casts, or proteinuria. The urine sodium was less than 10, and the FeNA was less than 0.1%. So what's your next clinical decision? Furosemide, norepi, terlipressin, octreotide and mitogen, or insert HD catheter? Okay, great. So majority of the audience saying go ahead with vasoconstrictor therapy. Okay, so let's move on to vasoconstrictor therapy. So again, this targets splanchnic vasodilatation as the sentinel event in the development of HRS, and there's long-standing experience of over 30 years with various vasoconstrictor regimens, both in the US and internationally. In the US, the three main approaches that we use in combination with IV albumin are mitogen or octreotide, norepinephrine, or terlipressin. And importantly, we need to balance efficacy and safety. And in patients receiving vasoconstrictor therapy, we need to monitor for the development of both cardiovascular and respiratory adverse effects. And we'll talk about that as we look at some randomized controlled trial data in a minute. So when we compare the three vasoconstrictor regimens, we see that only terlipressin is FDA approved for the treatment of HRS AKI in the United States. Both the AASLD and the ADKI guidelines suggest terlipressin as the first choice agent, followed by norepinephrine, with mitogen and octreotide being recommended when neither of the first two agents are available. Of course, norepinephrine has to be given in the ICU under cardiac monitoring and with a central line. Mitogen is an alpha agonist, which produces peripheral vasoconstriction. Octreotide is a somatostatin analog, which reduces splanchnic blood flow. Norepi, of course, is an alpha and beta adrenergic agonist, which causes peripheral vasoconstriction. And then terlipressin is a synthetic vasopressin analog with preferential affinity for the V1 receptors in the splanchnic circulation. So how do we dose these medications? So the FDA label for terlipressin says that the dose is 0.85 milligrams IV every 6 hours. We can double the dose on day 4 if serum creatinine has not increased or not decreased by more than 30%. ADKI recommends using a continuous infusion at 2 milligrams per day, increasing 2 milligrams every 24 hours to a max of 12 milligrams per day. Norepinephrine, again, is recommended if terlipressin cannot be administered, and ADKI recommends giving a continuous infusion of Norepi at 0.5 to 3 milligrams per hour, increasing every 4 hours in steps of 0.5 milligrams per hour to achieve a MAP increase greater than 10 millimeters mercury, or an increase in urine output greater than 50 mils per hour for 4 hours. And again, MNO are recommended when neither terlipressin or Norepi are available. Mitogen is dosed at 7.5 to 15 milligrams every 8 hours, and octreotide at 100 to 200 micrograms. Importantly, albumin at 20 to 40 grams per day is recommended, with the dose being adjusted based on the patient's volume status. Importantly, we should discontinue albumin in patients who have fluid overload or pulmonary edema. So what does ADKI say about the monitoring and the adverse effects of these agents? So both terlipressin and Norepi can cause ischemic events, including cardiac, peripheral, and mesenteric ischemia. Terlipressin, we also have to be on the lookout for pulmonary edema, and we have to be cautious in patients who have volume overload. Norepinephrine can also cause cardiac arrhythmias, and as I pointed out earlier, needs a central line and ICU level care. And mitogen can cause bradyarrhythmias. So next, let's turn to the clinical trial data, in randomized clinical trial data that support the recommendations that I just discussed. And we'll show a handful of studies for examples. So first is a randomized controlled trial of mitogen and octreotide versus terlipressin. And in this study, terlipressin was given via continuous infusion and was compared to dose-escalated mitogen and octreotide. Both groups received IV albumin. So as you can see here, there was a statistically significant increase in the rate of HRS reversal, both complete or partial, with terlipressin treatment. And this was associated with a statistically significant increase in the mean arterial pressure by day 3 in the terlipressin group in comparison to MNO. What about adverse effects? So we see that there were comparable rates of both abdominal pain and circulatory overload between these two vasoconstrictor agents. There was also arrhythmias noted in the MNO group, probably attributable to the mitogen. Next, let's turn to randomized controlled trials of terlipressin versus norepinephrine. This is a busy slide, and I just want to point out a few things. Many of these studies were relatively small, and when you look at how the agents were dosed, terlipressin was dosed according to changes in serum creatinine. Norepinephrine was dosed according to changes in mean arterial pressure, When we look at HRS reversal rates, you can see that they vary between studies, but within studies, the rate of HRS reversal between the two agents was comparable. If we look at adverse effects in these studies, and I pulled out the largest study here to look, are we seeing respiratory failure signal here, for example? We see, not surprisingly, a higher rate of GI side effects, including abdominal cramps in patients receiving terlipressin, a higher rate of chest pain in the patients receiving norepinephrine, but there was no reports of pulmonary edema, respiratory failure in this study, in that study. So next, let's look at the CONFIRM study. So the FDA approval of terlipressin in the United States was based on the landmark phase 3 randomized controlled trial that was published in the New England Journal of Medicine in 2021. And this was the largest vasoconstrictor trial for HRS treatment published globally to date. So the primary endpoint in the CONFIRM trial was a composite endpoint called verified HRS reversal, which included short-term survival, improvement in kidney function, and avoidance of dialysis. And as we can see on the left, there was a statistically significant increase in the rate of verified HRS reversal with terlipressin. On the right, we see statistically significant reductions in the rate of renal replacement therapy through day 30 in patients receiving terlipressin. So what about adverse events here? So not surprisingly, there was a higher rate of adverse GI events in patients receiving terlipressin, including abdominal pain, nausea, and diarrhea. Somewhat surprising was this higher rate of respiratory failure in patients receiving terlipressin, because this has not been seen in some of the prior randomized controlled trials. So a number of subgroup analyses were performed to identify factors that predicted the development of respiratory failure in these patients. Dr. Nadim discussed some of this earlier when she discussed the rate of albumin replacement in some of these patients. But let's look at some of the other factors. The key thing to take away from this slide is that patients with a serum creatinine greater than 5 or who have acute on chronic liver failure grade 3 have a lower rate of HRS reversal with terlipressin, have a higher rate of serious adverse events, and had higher mortality. And so this informed the product label in the United States, which indicates that we should use terlipressin in patients with a serum creatinine less than 5 or who have ACLF grade 0 to 2. Importantly, we also need to consider the patient's volume status and their oxygenation status. So again, we want to avoid the use of bolus dose terlipressin in patients with ACLF grade 3. In patients who are hypoxic, we do want to not initiate terlipressin until oxygenation levels improve. We may need to discontinue terlipressin should the patients become hypoxic on therapy. In patients who are volume overloaded, and as Dr. Nadim discussed earlier from the European perspective, we may need to optimize volume status prior to initiation of terlipressin by stopping fluids, judiciously using diuretics, and then implementing terlipressin. In patients who develop volume overload during treatment, we may need to stop terlipressin, use diuretics, and stop fluids, and then optimize their volume status. In the CONFIRM trial, when respiratory failure did occur, it occurred at a median onset of 5 days and an average onset of 7.5 days with a range of 1 to 67 days. So what about, how does this patient selection impact outcomes? And so I'm showing you some data that we presented last month at the annual CRRT meeting, where we looked at pooled data from CONFIRM and REVERSE, 2 North American randomized controlled trials of terlipressin. And what we're showing here are data in the label-specific population, so patients with serum creatinine less than 5, MELD score less than 35, and ACLF grade 0 to 2. On the left, you can see, again, statistically significant increases in the rate of HRS reversal with terlipressin. And on the right, what we're showing here is that administration of terlipressin and reversal of HRS in these patients did not negatively impact liver transplant rates in these patients, as we see similar rates of liver transplant between terlipressin and placebo at day 30, day 60, and day 90. So let's go back to the case. So terlipressin is administered at 0.85 milligrams IV every 6 hours. Serum creatinine has come down from 2 to 1.4, but the pulse ox drops to 90% and the patient's respiratory rate increases. So what is your next decision? Continue terlipressin, increase terlipressin, pause terlipressin and observe, or discontinue terlipressin and transfer to the ICU for norepi? Okay, good. I think, pause terlipressin and observe is a reasonable option, and some people would discontinue terlipressin and perhaps transfer to the ICU for norepinephrine. So all of the following are reasons to stop terlipressin except, serum creatinine continuing to increase, a complete AKI reversal, starting dialysis, developing hypoxia, or a urine NGAL less than 220. Okay, good. Yeah, so we want to stop terlipressin when the patient has kidney function kidney function is not getting better, if they have complete reversal, if they start dialysis, or if they develop hypoxia. Urinary NGAL levels don't yet direct our terlipressin therapy. So we discussed the challenges of respiratory failure and other adverse effects in patients receiving terlipressin. We also discussed the challenge of managing HRS-AKI in patients with ACLF. So are there other ways that we might be able to handle this? And so continuous infusion of terlipressin may be one way to handle this issue. So shown here is a randomized controlled trial comparing norepinephrine versus continuous dosed terlipressin in the management of AKI in patients with ACLF. So here, terlipressin was infused at 2 to 12 milligrams per day in combination with IV albumin, and norepi was given at 0.5 to 3 milligrams per hour in combination with IV albumin. And we can see statistically significant increases in the rate of HRS reversal at day 4, day 7, and at the end of treatment in patients receiving terlipressin. Notably, we saw an improvement in survival in patients receiving terlipressin in comparison to norepi. When we look at the adverse events that took place in this trial, again, we saw a higher rate of GI adverse events in patients receiving terlipressin, a higher rate of norepi, or a higher rate of hypertension in patients receiving norepi. Notably, the respiratory failure signal that was present in CONFIRM was not present in this trial that was performed in patients with ACLF. So this suggests that continuous infusion of terlipressin may be advantageous in overcoming some of these challenges that we've discussed. So the take-home points for my talk are that the differential diagnosis of AKI is broad and that we need to differentiate pre-renal ATN and HRS from one another. We want to treat HRS-AKI in a timely fashion with vasoconstrictors and albumin. Terlipressin has the most randomized controlled trial data. We need to think about the use of continuous infusion terlipressin as opposed to bolus dosing. Norepi has good data, but it requires ICU admission. Mitogen octreotide should be considered a third-line agent when terlipressin and norepi are not available. And in patients who are considering treating with terlipressin, we need to pay attention to their baseline serum creatinine, their oxygenation, and their ACLF grade as we select patients and as we monitor for adverse effects. Thank you.
Well, good morning. Again, my name is Hugo Vargas, and I am hopefully going to pivot and take you in a direction that hopefully will take all of the lessons that you learned from the prior two speakers about addressing the differential diagnosis and early management of renal dysfunction in patients with liver disease and take a perspective from a hepatologist's point of view. My disclosures are here. I have done work in this field now for what sounds like 20 years. Hopefully we're at a point where we can actually begin to reap the fruit of all of that effort. My objectives are really to touch about renal disease and liver transplant candidates, patients with advanced liver disease, discuss the impact of MELD and how we've been managing these patients and how that has impacted the majority of the patients you're actually dealing with. And I want to continue to highlight from the hepatologist perspective the impact of acute kidney injury in our patients' outcomes with respect to liver transplantation, their candidacy, and how I view the management of these disorders in that clinical setting. And then there is a tsunami coming our way in hepatology on the basis of what we're seeing our patients present with from metabolic liver disease that leads to cirrhosis that is accompanied by a lot of kidney dysfunction that was already highlighted. And I think that's really going to change how we approach these patients. And we're more than ever going to need your help in managing patients with advanced liver disease. So let's continue with the patient case. As we discussed, terlipressin was paused. 2 days later, the patient develops an infection. There's fever, jaundice, right upper quadrant pain, and he was started on ceftriaxone 2 grams per day, prednisolone 40 milligrams. By day 3 following the terlipressin pause, serum creatinine is now 2.2 milligrams per deciliter. The MELD score is 35. Total bilirubin is 16. Serum creatinine is 2.2. And here's the course of the patient's creatinine after the pause. So the question I'm posing to, I apologize. What is the most important item for kidney failure in this patient? Restarting terlipressin, transferring the patient into the ICU, liver transplantation. In the interest of time, of course, liver transplantation is very important in this patient population, but I think that the severity of the liver disease would speak to a lot of us about the appropriateness of continuing terlipressin at this point. I think this patient probably belongs in the ICU as he's getting sicker, clearly, and hopefully there we can actually manage his kidney function and lead the patient towards a successful liver transplant. So day 5 following terlipressin pause, 3 days after infection has started, bilirubin is now 25, creatinine is 4.2, potassium 6.2, MELD is greater than 40, and he's tachypnic, oxygen saturation is down, blood pressure is 91/54. What would you guys recommend at this point? I think it's clear to this room that this individual is critically ill. This patient probably needs to be in the ICU, and CRT is usually the way that I would see my colleagues lead this patient down that path, and then obviously continue to monitor and see whether the patient is indeed still an appropriate transplant candidate. His MELD score is quite high, so that leads us to be hopeful that we'll be able to achieve a transplant at this point. So again, as I mentioned to you, focusing the idea of liver transplantation being very closely linked to the patient's renal function is the result of applying our knowledge that came along with the application of MELD. When MELD was introduced, it had been a tool to assess patients with advanced liver disease vis-a-vis their candidacy for a TIPS placement. And the idea that we could actually make very objective decisions about candidacy and listing patients in the liver transplantation list on the basis of this type of parameter led to the implementation of the MELD score, which has been modified over the years on 3 different occasions. It highlights the very high prognostic value of renal function and the survival of patients who are candidates for liver transplantation, and indeed patients with advanced liver disease regardless. And unfortunately, it has some impact on the use of simultaneous liver-kidney transplantation, or SLK. It has had a significant impact on the cost and complexity of transplantation, particularly liver transplantation. But I think it, as you have probably observed, it also has impacted the outcome of kidney alone candidates for many reasons that I will point out. So definitely SLK has grown due to MELD. I will have more data later in the presentation regarding this, and this growth has led to valid concerns about the impact on potential kidney transplant recipients. Initially, when SLK was growing, there really were no rules for listing patients with the combined liver and kidney transplant, which has now grown to the point where it's the most common combined solid organ transplant procedure that we do in this country. There was always a very valid question about the potential return of native kidney function despite the transplantation that has been shown on many patients. And so there was a need for ascertainment of exactly who really needed the kidney, and that's something that hopefully has been addressed and will continue to be refined down the road. And there's obviously some data that I think is very impactful, and we need to be mindful of that, and that is that lower KDPI organs usually will go to SLK recipients preferentially, and that diminishes the impact to those patients who are getting kidney transplant alone. And I think we need to be very judicious about the use of a kidney in a liver transplant patient. And I think that that's something that hopefully I will show you that we are making strides in the right direction. Although, as was pointed out, because if we are seeing so many more patients with chronic kidney disease coming to liver transplantation, it is going to be a challenge to meet the needs of those patients at the same time as we're transplanting livers to really address what the renal function will mean to their outcomes after transplantation. So what do we see in the liver transplant population? We've already had a very elegant presentation of the concept that AKI is very prevalent in the course of the management of a patient with advanced liver disease. Hospitalized patients usually come into the hospital because of AKI or develop AKI as a result of an infection or another systemic injury while hospitalized. The vast majority, as we saw already, at least are somewhat volume responsive. Some will develop HRS or already come in with HRS. And the message that I want to leave you with is that the resolution of AKI usually leads to better 90-day survival. So it behooves us to be very cautious as a team to ensure that anybody who can reverse the course of their AKI, that we do that. This is a very simplistic presentation, what has already been said. I think we worry a lot about pre-renal causes of AKI and intrarenal causes of AKI, all of which can potentially lead patients to present with hepatorenal syndrome and or be presenting at the same time as it was already mentioned. Generally, post-renal AKI is not as common. As you will see here in this slide that you've already seen, many patients present with pre-renal, almost as many as present with an ATN, and this is where we as hepatologists really need your help. I think that we can begin to treat pre-renal causes, but in many respects, we still don't have the tools available, and perhaps you don't as much as we don't, to really determine who's got ATN, because their course, as you see here, is almost as bad as hepatorenal syndrome. And I think it's very important for us to jump on this very quickly, reverse as many patients as we can, and then focus on what we need to do for those patients whose renal function does not recover after our interventions. In management of our patients who are listed for transplantation, we are always monitoring what's happening to the kidney function. And I think this retrospective study, which was done very elegantly by Dr. Kulara and his colleagues at UCSF, looking at patients who were listed, very carefully curated to ensure that they could clearly identify those who had either acute kidney or chronic kidney disease identified, or a combination of both, and then assessing what happens to those patients on the list. It's very impressive to see the impact of AKI to any of those patients, and particularly if it presents in a chronic setting, the mortality increases significantly. And this is after accounting for competing risks. So it is very important to note this. And I don't have time in the presentation to highlight that this group also showed that the higher the MELD, the more likely it is that AKI, particularly AKI in combination with chronic kidney disease, will impact the survival of the patient on the waiting list. So it's very important for us to be very mindful of AKI and how it impacts our patients in the liver transplantation list. Further highlighting this, I want to show you what we see in published data about the type of AKI and the response of AKI. As you can see here, with patients that have a very mild AKI that returns to full renal function as a reference, the more severe the AKI, and particularly as the progress of the patient on therapy moves on, it is more and more likely that those patients who don't respond very well or who have very severe injury will end up having a much more significant morbidity and mortality in the 90 and 1 year timeframes. So a very important point is that response, if it's durable and maintained, will actually lead to patient survival of the patient so that we can actually get them to liver transplantation. So I'm going to, again, enhance from my perspective some of the elements of what has already been said. We like to prevent any sort of acute kidney injury. I know that there are some differences of opinion. I think albumin administration judiciously can help our patients. I think that any volume depletion that may be present will actually help our patients. And if we address it, whether we use crystalloids or albumin, I think that every patient is different. I think that fluid overload is very problematic in our patient population. So we need to be, again, very cautious and careful and working with partnership with our nephrology colleagues to get this situated. I'm sorry, just get back to, I don't know what happened here. So emphasis on using judiciously albumin when we're actually draining ascites is probably the most important thing that we do to prevent renal dysfunction in our patient population. There has been some data, which I think is still quite controversial, about the chronic use of albumin in patients with decompensated liver disease. And I think that in the future, we'll be seeing more emphasis on looking at what elements we can provide to patients to prevent renal dysfunction. So I think from the hepatologist's humble perspective, I don't want to see you guys getting involved in my patients. I want to prevent them from having renal dysfunction at all cost. Hemodialysis, very important. I will never say that I don't want dialysis in my patients, but I still think it's a bridge to transplantation, and the less renal replacement therapy that I see in my patients, the less likely I am to see renal dysfunction post-liver transplantation and decreased quality of life as a result of that. This is an elegant study, again, retrospective, done by Patien a few years ago, that highlights in those patients who received renal replacement therapy, looking at those who didn't recover and died after liver transplantation, you can see that the lower the duration of renal replacement therapy, the more likely you are to actually have a full recovery of renal function and decrease the mortality of those patients. It's important to realize that renal replacement therapy for less than 90 days is usually followed by excellent renal recovery in 90% of those patients who receive liver transplantation. There's still significant mortality 6 months post-liver transplantation, but adjusting for renal recovery, a 3.6% per day risk of renal dysfunction post-liver transplantation is noted. And the risks for non-recovery are very obvious, but I think are very important to bear in mind because we are really barreling through this idea of transplanting older and sicker patients, and obviously a lot of patients with diabetes. So again, previous liver transplant recipients, patients who are advanced age at liver transplantation, and pre-liver transplantation diabetes leads to non-recovery after renal replacement therapy pre-transplantation. So very important to keep that in mind. I want to, again, hammer the fact that we see that early treatment of hepatorenal syndrome leads to far swifter recovery and response. And I think that the point that it hasn't been mentioned often enough, my patients are sarcopenic. Even the very obese don't have the muscle mass. So creatinine may not be the way to look at renal dysfunction. Perhaps we need to be looking at cystatin C or any other option, but keep in mind that a creatinine of 1.2 in a patient with advanced liver disease may not be normal because that creatinine is not representing the degree of renal dysfunction that they have. And again, the patients who respond to terlipressin will remain free of renal dysfunction after liver transplantation. That was already pointed out. We are not hurting patients by treating them with terlipressin, even though their creatinine improves because they are transplanted at very similar rates. The data that's actually important to keep in mind is that in the hands of Europeans using infusions of terlipressin, if you have a responder that is treated before liver transplantation, they did not observe a significant number of them going on to renal replacement therapy after transplantation. So it's important to keep in mind that the likelihood of sustaining a response in patients prior to liver transplantation may lead to better renal health post-liver transplant. And as you can see here, again, patients that develop chronic kidney disease who are responders to terlipressin is very similar to those who never had any renal dysfunction prior to liver transplantation, and much more significant in those patients who were non-responders to terlipressin. So I think that very important to discern who's actually going to respond and to apply this. Similarly here, the probability of survival is very good in those patients who respond. I think that the probability of survival with no chronic kidney disease is a little bit better. And so if you can actually get patients to go to a status post-liver transplantation where there is no chronic kidney disease, I think we'll be attaining goals that are common to all of us. So I think that currently, liver transplantation is the only current curative approach for cirrhosis. And when you have hepatorenal syndrome that isn't responsive to therapy, that's probably the only way we're going to try to get people to a life without the need for a renal replacement therapy. However, there's still some concerns in the transplant community, particularly in the side of the liver transplanters, that decreasing serum creatinine, decreasing the MELD score will negatively impact those patients who are listed. I would purport that is not the case, that I think that there is no decrease in prioritization, and that a patient managed with normal renal function in the operating room is a far safer patient to see go through the process, who will have less post-liver transplantation morbidity and mortality. The impact of AKI liver transplantation currently then remains as follows. I think the renal function may not recover fully post-liver transplantation. About 25% of those patients remain dialysis dependent post-liver transplantation. And again, patients who have chronic kidney disease are ones that we really pay attention to, because the current strategy of doing simultaneous liver kidney transplantation, as I will point out soon, is not ideal. Dialysis within 90 days post-liver transplantation was the strongest risk factor for progression to the need for chronic dialysis. So I think that if we act quickly and prevent the need for a renal replacement therapy, I think that we are doing our patients a great favor. I think it's extremely important that for those of you who work in sites where there is no liver and kidney transplant available, to contact transplant centers quickly to make us aware of patients who may need to be treated aggressively in order to prevent those patients from progressing. I find that many times in my site, we see patients way too late, and I think that once we are advanced towards renal replacement therapy, that's going to be a very difficult task for us to overcome. The impact of successful AKI treatment, obviously, we decrease all the potential consequences of a decreased priority, that is decreasing the MELD, the duration of kidney injury, the presence of Patien impact the likelihood of renal recovery, as I've already illustrated, and post-liver transplantation, renal insufficiency and requirements for renal replacement therapy are correlated with decreased liver transplant survival and decreased quality of life for those patients. Post-liver transplantation, again, we talked about this post-operative AKI. There are many reasons for this. Patients' hepatorenal syndrome can persist after transplantation. There are intrarenal etiologies. We intervene and do a number of maneuvers in our patients that injure their kidney function. So I think that going into liver transplantation already with a failing kidney probably complicates the course of management. And I think that a lot of the drugs we introduce are actually going to make the management quite difficult. So now I'm going to shift very quickly to talk about the chronic kidney disease patient. The current challenges is that there are large numbers of patients with chronic kidney disease that are being evaluated for liver transplantation. Steatotic liver disease, which is what we now call fatty liver disease, leading to MASH or advanced hepatitis as a result of fatty infiltration of the liver, leads to cirrhosis, and this is climbing very rapidly. It's become the leading cause of liver transplantation in Western societies, and it's likely to stay with us for a long time unless we actually are able to, as a group, all treating clinicians who are seeing patients with steatotic liver disease, make a difference. HCC usually accompanies this disease as well, and unfortunately that may bring patients who have earlier liver disease presenting for a need for liver transplantation, which further burdens the need to transplant and the need to act in respect to this problem. As you can see here, the numbers we're talking about, even though those presenting with very advanced liver disease in the orange shades here are not as significant as all others, we're talking about millions of patients. So this is where we're seeing the burden on the liver transplant community. So what are the options that we have? We talked about the combined liver kidney transplantation. As you can see here, when the MELD was introduced, this was really a handful of patients that were being transplanted in this fashion. Soon after that, the realization that the kidney was also involved in the pathogenesis of the process led a lot of surgeons to transplant more aggressively, and we reacted. The orange arrows here shows us at the points at which we had consensus conferences to address the growing demand of kidneys taken away from the the kidney alone recipients to be used for combined liver kidney transplantation. And the community implemented a rule in 2017 to change that process and to really establish a set of rules that lead to very specific patients receiving a kidney if they needed it. That has changed the trajectory. I think if we hadn't acted and done that, you can see here in the dashed line, the numbers of SLKs will continue to grow, and that's actually tampered down. It hasn't really decreased the numbers, but we're actually probably treating more appropriate patients now at this point. So here are the SLK allocation rules. I'll be very brief. You need to demonstrate chronic kidney disease as illustrated by a GFR less than 60, for greater than 90 consecutive days, and they have to have initiated renal replacement therapy, or the eGFR has to have decreased to less than 30 at the time of the kidney registration. Patients also have to have sustained kidney injury, as outlined here, with dialysis for greater than 6 weeks. And of course, there are metabolic diseases that get you the allocation of a kidney at the same time as a liver, as outlined here. Additionally, it's very important to recognize that if we choose to transplant a patient who may need a kidney at the time of liver transplantation with the liver alone, we now have access to a safety net that allows us to allocate at a higher priority a kidney transplant for those patients who do not successfully retain excellent renal function after transplantation. So I think that this is another avenue that we have where we can avail ourselves of the appropriate use of the organs. Just to end, I think that looking at what happens to our patients with chronic kidney disease while on the list is extremely important to make decisions. As you see here, patients who are on the list with chronic kidney disease and have and are listed for simultaneous liver kidney transplantation actually will do quite well if they attain an acute kidney injury in the process of waiting for liver transplantation. Their mortality increases significantly. But if we look, it's particularly important to pay attention to those patients who go on to receive a liver transplant alone, who are listed for simultaneous liver kidney transplantation. Their mortality is actually quite higher as one would expect. So it's probably very important to, if you have somebody who's appropriately listed for simultaneous liver and kidney transplantation, you go on and transplant them together, as they will do quite well. So the take-home points from this discussion, I hope that we left you with the idea that AKI is very common in cirrhosis. This may increase the MELD, but also impacts the outcome. Treat aggressively. The cost of MELD will be present as has been illustrated, but the survival benefit warrants managing it aggressively, even at the cost of decreasing the MEL in these patients. Treat these patients early, prevent AKI if at all possible, use terlipressin and albumin judiciously. There are very specific rules as to how we do this. And chronic kidney disease and non-responsive AKI may warrant simultaneous liver kidney transplantation. Understand that there are very specific requirements to list these patients. Unfortunately, SLK is not as good as a liver transplant alone. So it would be very important to ensure that any patient who can prevent having the impact of a simultaneous liver and kidney transplant be listed appropriately. Thank you.
So we do have time for Q&A, and we do have several in the chat. I have it. So feel free to come to the mic, too, if you have questions.
Hello, my name is Patien. I practice in Lewiston, Maine, so it's kind of more of a rural setting. So 2 questions real quick. One is complicated, one's probably not. We don't have terlipressin. Our ICU is fairly small, so it's hard to get people in there to get on norepinephrine, so they get the midodrine or midodrine and octreotide cocktail. So my one question with that is, I know it's a little bit different mechanism, but norepi, if we could get them norepi and we have vasopressin, I know it's a V1, V2. Is there anybody, did they look at that? I may be ignorant about that to see, is there any benefit to putting a vasopressin drip on with norepinephrine on somebody that's in the ICU if we could get them there? That's one. And then the second question is just, we are seeing a huge uptick in liver disease, where it used to be a couple times a year. Now we continuously have somebody on our service with HRS, or we're ruling it out. From a medication standpoint, I know there's metabolic issues with this. Statins, we're using high doses, other medications coming on the market. Is anybody seeing a trend that you guys are paying attention to as far as medications they're on that we need to start paying attention to?
Sure, great. Dr. Vargas, you want to answer the second question?
Yeah, the second question, I think if you pay close attention, we obviously see a lot of patients with advanced liver disease. I think that, as I tried to point out, there is an immense growth in steatotic liver disease. So you may be seeing patients with diabetes. I think that when I remember how I was trained, I was never really taught that diabetes actually impacted the liver significantly. But the reality is that many of our patients with diabetes have advanced liver disease. I think there's a significant increase since the pandemic on alcohol consumption. I'm seeing a lot of very young women presenting with very advanced liver disease in hepatorenal syndrome, many of them with alcohol-related hepatitis, but many of them with advanced chronic liver disease that then now engages the kidney. Because I think that, unfortunately, what we see is that cirrhosis and renal dysfunction are very intricately intertwined. So I'm not surprised you're seeing more patients in your service.
And with respect to the first question, and there are a few other questions in the chat that are very similar about vasoconstrictor agents, M&O, combinations of vasoconstrictor agents. There's no good data with respect to combining vasoconstrictor agents. And there's also not great randomized controlled trial data to support the use of vasopressin. Mitra, do you want to comment on that, Dr.
No, I mean, again, you're right. There's no point in adding 2 vasoconstrictors because, again, all of these vasoconstrictors have side effects. It's like someone who's in shock and you put them on levovaso, they get arrhythmias and, ischemic changes. So, combining them makes no sense. If you do have access to terlipressin, again, because it's much, much stronger splanchnic vasoconstrictor than the other ones, then it would be the way to go. If not, again, the problem with norepinephrine we keep forgetting is the dose is really high. I mean, we never think about it, and that's why it requires a central line, because you can give norepi peripherally if it's only 3 mics a minute, but we're talking about 15 to 30 mics. This is 3 milligrams an hour. So if you do the math for the pharmacist, it's a lot of norepi, and just taking a patient and putting him on there, the next thing you know, the surgeon or hepatologist or ICU is going to do a sepsis workup because they're like, why is the patient on, 30 of levo? So, and if you have only octreotide midodrine, well, something is better than nothing. And the only recommendation I would have is just start at a high dose. We do this 5, 7.5, just hit them with 15 and octreotide. And again, if your MAP does not increase, it's not going to work. But if that's the only drug you have, it's better than nothing.
And if I may add, vasopressin, you need to use it in the ICU, at least as far as in my environment. And terlipressin is a prodrug for vasopressin. So all you're going to do is give terlipressin on the floor. I mean, you should lobby your P&T committee to try to get you terlipressin available to you on the floor, because you can use it without transferring the patient to the ICU. You can see the patient very quickly. And again, in the cirrhotic patient, don't go by the usual creatinine guidelines. Really really search to see what the patient's prior creatinine was before you saw him, because I think the reality is that these patients usually will have very low creatinines because they have very low muscle mass. And then when you see them with a creatinine 1.2, you may not be alarmed, but you may be dealing with frank AKI at that point that needs to be addressed aggressively.
And the point that Dr. Vargas made, again, if they're in the ICU, the purpose of terlipressin is really to avoid going to the ICU. If you're already in the ICU, then, the data, it doesn't support either norepi or norepi versus terlipressin. The norepi is going to be really cheap compared to that, to the terlipressin. You put the central line, but if someone's in the ICU by then, they probably have a central line for other reasons. So again, and by that time, a lot of them are probably in shock for other reasons. So really the purpose is to avoid again, a lot of the hospital committees or P&T or administrations, pharmacy worried about the cost. But if you do the math of the cost of the ICU versus the cost of terlipressin on the floor, it actually ends up being much cheaper for the hospital. Especially, again, at our hospital, we have 90 ICU beds, but you have to be at your deathbed to get into the ICU these days. You cannot, if you have someone who looks good, which an HRS patient may look good, and you say, well, I want to send them to the ICU for infusion of norepi, it's not going to happen. Most centers will just block it because they need the ICU beds.
Okay, another question. Do GI adverse effects events warrant discontinuation of terlipressin? I guess it really depends on what the adverse effect is. If it's a little bit of abdominal cramping and some diarrhea, probably not. But if there is evidence of ischemia, then yes. If the GI side effects are significant enough and troubling to the patient, you may need to, instead of dosing every 6 hours, maybe you need to span the dose out longer and wait and observe. Any other thoughts on the GI effects?
I think that's actually a really good question. I think that one thing that I do personally is when we started terlipressin, we actually, the older individual who I had more concerns about potential impact of actually vasoconstricting the splanchnic bed, I gave them half dose. There's nothing wrong in starting with half dose terlipressin, see how they do, and then gently increase the dose. The infusion, which I've implemented now in the Mayo Clinic, actually all Mayo Clinic has available infusion of terlipressin, much less side effects. So I think that's another option that I think is underestimated, and the Europeans really fully endorse that because they've been using it for a long time, and with the IV infusion, they see a much better result in terms of side effects.
So, Dr. Nadim, this next one I'll give to you, and maybe what you and the ADKI group thought about this. How do you account for concomitant heart failure in the pathophysiology and management of HRS?
Well, that's a tough one because there's all this discussion. I mean, again, the involvement of cardiac, cardiomyopathy and HRS, and it's something to consider. But would it prevent you from treating someone? I would say no. I mean, I'll leave it to the hepatologist to comment.
This point actually brings up the concept First of all, I think that there are patients who are very advanced who have a cardiomyopathy related to their liver disease. I am a believer in that. I also think that at the point at which hepatorenal syndrome may be presenting, you may be seeing what we call ACLF. Now, most hepatologists aren't very familiar with ACLF. I think that in the nephrology field, it's probably not going to be something that you come up with all the time. But I think that systemic decompensation that is rapid, that involves more than one organ. So the kidney, the lungs, the heart may be failing at the same time. I think that's a real thing. And I think that at that point is pretty late in the game. And I think that those patients need a liver transplant urgently. And I don't know that we give them high enough priority. So there could be an element of that in the picture.
Yeah, I think we do see a lot of that overlapping heart failure, cirrhotic cardiomyopathy, and that can manifest as the pulmonary edema when you start a vasoconstrictor and you get afterload and you get preload increases. And so, again, this goes back to the point about managing volume status, using diuretics, especially once you've implemented vasoconstrictor therapy and the blood pressure goes up. And then with respect to management of dialysis, there's a question in here about, do we start dialysis earlier than we might in patients without cirrhosis, especially if they're listed for transplant? And perhaps this is one of the reasons to bring down the RVSP prior to liver transplant. We need to be watching for that. Okay, let's see. We probably have time for one more question. Do you recommend the Royal Free College equation, GFR? Or any other GFR equation?
So the Royal Free, for those who don't know, it was one study from the UK. They came up with a specific GFR equation specific to liver patients, but it also includes elements like ascites. So, and it was never really validated. And again, once you put in subjective metrics like ascites, it becomes, in my opinion, not valid. There's an equation from Baylor looking at 10,000 iothalamate, and they call it the GRAIL equation, which it's in revision for number 2. It basically uses the same elements that was used for the CKD epi, but it's just adjusted for different, how much value you put for each based on the liver patient. So, and they've shown that compared to CKD epi, it actually, in patients with liver disease, it performs better. The issue is that for right now, currently, especially for SLK, you can't use an equation that has not been, formally approved. So our recommendation at the AKI was to use this, the CKD epi that currently exists, the 2021 without the race element. If you do have cystatin C, as was mentioned, I would highly recommend it in patients with liver disease. Yes, it does have some flaws associated with it, but compared to serum creatinine, so we have it in our patients. A lot of them, I ask them to send it because they think I'm crazy when I want to start dialysis, that the creatinine is 1.7. But you look at the patient and you know that GFR, the patient, the hepatologist keeps giving lactulose and they're not waking up. And then you do cystatin C and it's like 3. So really, if you have it, do the cystatin C, CKD epi cystatin C GFR. If not, then with this, the CKD epi creatinine would be the GFR for now that you can use, again, for SLK and things like that. I think there was also another question on albumin, if you want to. I think there was 3 questions on whether there's any studies with albumin versus crystalloids. No, there's no studies, but you have to think in a patient non-cirrhotic, if they have come in with vomiting, diarrhea, too much diuretics, what's the first thing you jump to? It would be crystalloids. And again, you can give a buffered one, like whether it's LR or plasmolite. That would be the first one you jump to. Again, the issue is that if a patient is very volume depleted, because we sometimes get called that, okay, the hepatologist gave, no offense to the hepatologist, but they give the 2 days of albumin and they call us because the renal function is worse and they're like, is this HRS? And then you look back, the patient has 0 edema, was saying that, they were either on diuretics or a lot of lactulose, diarrhea, wasn't eating well. And, 100 cc's for 2 days, if you give 3 bottles a day, so that's 300 cc's, that's not enough volume for someone that's under resuscitation. But if you give them and again, that's why I like the old definitions of HRS, where they gave a liter or liter and a half of crystalloid, of volume for someone if someone has a massive GI bleed, you give them blood. So give them the appropriate fluid. Paracentesis, there's a lot of data. Yeah, you give the albumin, that's more for, prevention rather than the treatment of the AKI. So yes, there's no data, but you have to think, if there's no data, then why give someone albumin? The data with SBP, the thought was, can albumin have a different role, against infections? It has other immunomodulatory effects. But again, the data, there's a lot in the Europeans, non-SBP, albumin really didn't make a difference. So then you have to wonder, okay, does it have that property? And the answer is really probably no. My belief is that with the SBP data, it really was a volume issue that was given, and so they kind of did better rather than just the albumin issue. So if someone comes in with SBP in shock, give them volume back. Just giving albumin is not going to be, enough. Versus someone who, has a little bit of belly pain and the hepatologist does his SBP. If you want to give albumin, that's fine. I don't know if it has to be day 1 and day 3. I would just give day 1 and day 2. But if they're in shock, and again, this is a mistake that's made, everyone still goes day 1 and day 3. But if you're in shock, give the volume back. Treat a shock patient the same way, I think. But again, your thoughts on this?
I think that this touches on a lot of things. I think that the patient population that we see many times on the floor, I think the volume assessment is challenging. And I think we've tried several things. I think we're emphasizing the use of POCUS at the bedside to try to assess better volume status. So deciding what to do with the volume at the bedside sometimes can be challenging in this patient population, particularly when they have ascites and you don't really know what your patient's missing. In my practice, generally when I'm going to manage a patient with hepatorenal syndrome, I try to place a double barrel pick that I can actually measure CVP, so that CVP actually guides what I'm actually doing with fluid. And I get you guys involved in the care, because I think we have to manage so many different facets at the same time. Unfortunately, we don't always get the same recommendations. So there's actually some consistency.
But this goes back to, again, the 1979 HRS criteria where, they capped it CVP of 10. Mm-hmm. And again, it goes to that concept that even then they were thinking, give volume. My interpretation is give volume if they need it. If they don't need it, don't give it. Now, how you determine what they need or don't they need, again, is very challenging. I know a lot of people do POCUS, but you try to do POCUS on someone who has ascites and SBP, they'll just punch you in the face. I mean, you push that probe on them. So it becomes looking at the whole picture. What does the patient look like? What does the X-ray look like? What if you have an echo, what it is? If they do have a central access, what is the CVP? And if it's high, if it's suggesting high, maybe your decision should be, let's give it a chance. It could potentially be HRS. Let's not wait 48 hours. Let's start the treatment soon. And again, the Europeans, even though they have these guidelines, if you talk to them and the people who wrote those guidelines, if they even think, okay, it may still be 18, they still go ahead and give it. They'll have an answer in 48 hours. If you don't see at least a plateauing, it's probably not going to be after they've doubled the dose of the maximum dose in 2 or 3 days. You two have experience in 2 or 3 days, and it doesn't mean that in 2 or 3 days it has to be completely normal, but you got to see it plateauing and starting to go in the right direction. If it doesn't, and on maximum dose, you can pretty much stop it. And so that's why they have better success, because again, despite the guidelines, which I hope they would change, they do start earlier than what their own guidelines say. So again, if the volume is up, don't wait the 2 days. Just go ahead and treat if you've ruled out really some drug toxicity that exactly that was the cause. Short of that, I would say err on treating. It's safer rather than just waiting, because by the time you wait 2 days, it may be too late. The creatinine hits 4 or 5, you've missed the boat, and you can give it. The success is just going to be really low. And if your success is low, the pharmacy is going to stop it and the hospital is going to stop it. They're going to say, why are we giving these drugs when your outcome doesn't make a difference? They end up on dialysis.
Well, great. Thank you all for attending. Thank you to Dr. Nadim and Dr. Vargas for their great presentations. Thank you so much.